Welcome everyone to today's session of our NOW program educational webinars. Today's topic will be surgical approaches. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the NOW team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate the Q&A. If you have any other questions or more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Rachel Garcia Fox to introduce our panelists. Thank you.
Thanks so much, Sierra. Hello, everybody, and thank you for joining. Welcome to a new Neuro-Oncology Wellness Education webinar. The Neuro-Oncology Wellness, or NOW program, is an initiative from the Center for Neuro-Oncology at the Dana-Farber Cancer Institute with a mission to educate patients and their caregivers about brain tumors, as well as provide resources to promote overall health and well-being. My name is Rachel Garcia Fox. I serve as the program administrator for NOW, and I'll be your host for this webinar. Today, I am excited to be joined by Drs. Omar Arnaout and Linda Bee for a discussion on neurosurgical approaches for the diagnosis and management of brain tumors. Dr. Arnaout is an associate professor of neurosurgery at Harvard Medical School, associate director of the Neuroscience Intensive Critical Care Unit at the Brigham and Women's Hospital, and co-director of the Computational Neuroscience Outcome Center. Dr. B is an associate professor of neurosurgery at Harvard Medical School and associate program director of the Neurosurgery Residency Program at the Brigham and Women's Hospital. She also directs the Skull-Based Tumor Laboratory, where she studies the biology of skull-based tumors with a goal of improving clinical management and patient outcomes. Dr. Arnaout's and Dr. B's clinical practice is entirely devoted to the care of brain tumor patients, with both of them routinely operating on patients with gliomas, brain metastases, meningiomas, and other brain tumors. Drs. Arnaout and B, thank you so much for joining us today. Before we start, I want to remind our live audience we want you to be a part of this conversation by submitting your questions via the Q&A feature at the bottom of your Zoom screen. We'll select a number of your questions for our guests to answer in the second half of the program. So, Dr. Arnaout, thank you for being here. Why don't we start at the beginning? Can you help us define neurosurgery? What is neurosurgery? And what are some of the techniques that it uses to safely explore and hopefully remove brain lesions?
Yeah, thank you, Rachel. Thanks for having us. I think this is really exciting to have. So thank you for setting this up and hosting neurosurgery. So neurosurgery is a branch of the practice of medicine. It's a very specialized field. It actually encompasses the treatment of different kinds of brain-related issues, as well as the spinal cord and peripheral nerves. It's a pretty broad field. Our discipline involves diagnosing patients, treating patients, and then helping them get through also non-surgical treatment. As far as the issue of removing brain tumors and brain lesions at large, which I think is what we're focused on today, we have a lot of tools to try to do that really well and really safely. As you can imagine, the crux of brain surgery is that it has to be perfect. Especially with brain tumors, you really want to do a good job taking the tumor out, but you don't have the margin that some other surgeons, might have in terms of your ability to go above and beyond, where the tumor is usually. So to that end, we're lucky that we have access to just about everything under the sun in terms of our ability to do microsurgery, use microscopes and very specialized precision tools to take out brain tumors. We have access to neuronavigation, which we describe as GPS, basically, for brain surgery to help guide us down to our target. We have access to endoscopes, which are basically cameras that can also allow you to look through small openings and around corners. We have the ability to scan patients during surgery. You know, we can do ultrasound, we can do MRIs, we can do CAT scans while patients are asleep and getting surgery, which is an idea that incidentally was born at the Brigham, that was invented here at the Brigham many years ago. And if it's appropriate, we can also keep people awake during brain surgery. Those are all tools that we use to optimize our ability to take out brain tumors.
Fascinating. Thank you so much for that detailed answer. Dr. B, in previous programs, our neuro-oncologists have discussed that upon recognition of a brain lesion on an MRI, it's paramount to get neurosurgery involved as soon as possible. How is neurosurgery relevant to the diagnosis and the management of brain tumors?
Thank you for that question, Rachel, and for the wonderful gathering that we've had today. Neurosurgery is, I think, a key part of the triad of oncology, radiation oncology, surgery that deals with diagnosis and management of brain tumors. These days, especially because patients will undergo cranial imaging for many reasons, including headaches, ringing of the ears, sometimes a fall and bump of the head. So there are an assortment of brain tumors, benign or cancerous, that are found. Some of them do not need treatment, but should be monitored for a long time, possibly life. Others do need treatment. And in general, we think of those that need treatment as ones that are potentially cancerous or malignant to establish a diagnosis, ones that are growing over time, ones that are causing a symptom, and ones that may cause a symptom which could be irreversible in the future. And so for those indications or reasons for treatment, neurosurgeons play a role in both the monitoring and the decision for when to intervene. When intervening, one key aspect is obtaining a definitive diagnosis, which to this day, the majority of brain tumors can only have a diagnosis if you have tissue. There are a select few subtypes for which getting non-invasive tests can give us a pretty good idea, but most of them need a tissue. There are also, with advances in imaging and MRIs and such, that we have a pretty strong hunch, I would say close to 99% accurate in some cases. But even in those cases, when we know the general type of tumor, let's say a glioma or a meningioma or a vestibular schwannoma, there can be different genetic or molecular subtypes of the tumor that impact treatment and outcome. So tissue can still be important in that process. Beyond diagnosis, I tend to think that surgery offers one of two major advantages into patients, and that's to help with either their quality of life or their quantity of life, or both. And so sometimes surgery, by taking the whole tumor out, which you can see under the microscope, what's called a gross total resection, or close to that, what's called a near total resection, has significant ties to improving the overall survival of patients. And this is especially true in tumors like gliomas. And other times, a particular tumor, even a small tumor, can be adding symptoms, causing weakness, language difficulties, seizures, and removing that can be the fastest way to accelerate a patient's recovery. The very last category in which surgery can serve as an adjunct is as a bridge to other treatments, for example, clinical trials, or to make radiation more effective. So I think there's many potential roles for neurosurgery, and by working together as a multidisciplinary team, we can really suss out the pros and cons.
Wonderful. Thank you so much for explaining that, Dr. B. Dr. Arnau, back to you. So Dr. B was just mentioning the importance of a good tumor resection. She mentioned the term gross total resection, which patients often hear discussed in the clinic visits. What does a gross total resection mean? How commonly is this achieved?
Yeah, I think that's a really good question, Rachel. And it's a point that I think deserves a lot of clarification. So it's a term that we use all the time. It's a term that's used in clinical trials and in literature. And it really refers to this concept of removal of all the visible tumor tissue. And, visible here is a key word. Oftentimes, as it's defined with respect to high-grade gliomas, it really talks about the enhancing portion of the tumor. And the main thing that I think is important for patients and their loved ones to understand is that GTR, or gross total resection, is not always the same as a complete eradication of the tumor, which may be the intuitive thing to do, to believe rather. So especially with gliomas and also with other types of tumors, we know that there are invisible microscopic cells that none of us can see, that may be left behind, whether that's surgery or even with other treatment besides surgery, which can make these tumors sometimes challenging to treat. But a gross total resection refers to taking out everything that is visible, that is removable. The other thing I'll say is, how often does it happen? Well, that really depends. It depends on a lot of things. It depends on the tumor's location, its size, the involvement of surrounding critical brain structures. And like Dr. B said, it is a noble goal to have. It's something that we often strive to achieve because of the positive impact that a gross total resection can have on the long-term arc of the patient's experience with their tumor. What I often talk to patients about is that we have to weigh the extent of resection with the impact of sometimes being overly aggressive, especially in what we call eloquent or sensitive parts of the brain. So a term that I typically use with my patients, in addition to extent of resection and GTR, is this concept of maximal safe resection, which to me means I want to take out the maximum amount possible while preserving the patient's function and quality of life. And if that is synonymous in a particular case with gross total resection, fantastic. If it's not, it's really maximal safe resection that we're trying to achieve. It's the idea of threading that needle with extent of resection and quality of life.
Wonderful. Yeah, thank you for explaining that. It sounds like quality of life and removal of the tumor are really two equally important factors when you guys are operating. Dr. B, can you tell us a little bit about the techniques that are used intraoperatively to safely resect tumors?
Absolutely. I think this is an aspect that is in evolution, and we're blessed with all the technology booms across different domains and disciplines that we can tap into that in neurosurgery. I would say the first aspect of safe intraoperative resection comes from prior to surgery, and that includes testing such as better MRIs, higher resolution, including things like functional MRIs or techniques called tractography, where we can really see the relationship of a tumor with important parts of the brain, like motor fibers, language fibers, and so on. At the time of surgery, there are different strategies to do surgery, including having the patient asleep or awake. The ability to do awake surgery with anesthesia for certain types of monitoring is particularly important for tumors that are in the language areas, and that comes with evolution of a technique as well. In a sleep surgery, but also in some cases of awake surgery, there are also neuronavigation and imaging advances. As Dr. Arnault mentioned, we have very precise ways using both the registration of the patient's face and skull, but also things like ultrasound and other sort of advanced imaging tools to be able to really pinpoint where a tumor or a lesion is. In addition, we have the ability to do intraoperative neuromonitoring, which means putting in dozens of electrodes, sometimes hundreds, into the patient's major muscles, nerves that supply eye movements, voice, swallow, facial activation, sensory nerves. So we can really monitor a lot of different functions very well in the asleep patient. And some of these modalities are really rapidly evolving. Every 5 years, there's techniques that did not exist, a few years before. And so that's really pushed our boundaries, especially in highly sensitive areas like the brainstem, the motor cortex, to get at tumors safely. In addition, there are advances in dyes, special dyes like fluorescence, fluorescein 5-ALA, that allows us to see infiltrative boundaries of tumors better. And we have the ability to get an MRI while the patient is asleep, something called intraoperative MRI. So we have this whole barrage of tools that we're privileged to access. But ultimately, I think all of these tools are an adjunct to surgical technique. And that comes from training experience, but also evolutions in technique, including, for example, there's an entire domain of neurosurgery called skull-base surgery. And sometimes those techniques apply to, even though that was created for tumors outside the brain in the skull base, but some of those techniques are now so well accepted and practiced that we can apply them to tumors that are within the brain as well. So there's a lot of cross-fertilization of the surgical technique itself.
Wow, it's incredible. It sounds like if you guys come back even 2 years from now, you might have something new, a new technique that you're using. It's really exciting to hear about this from you guys. Dr. Arnau, let's start kind of a discussion about what people go through when they go through neurosurgery. If you were prepping a patient, for a neurosurgery, a craniotomy, what should they expect? What would you tell them to expect before their operation when they're admitted for the procedure?
Yeah, so getting ready for brain surgery is always a stressful time, and it's scary for patients. We often in clinic talk about how for us on this side of the world, doing brain surgery is just a normal Tuesday in the office. But for the patients and their families, it's often one of the most stressful things they've gone through. And we take it, obviously, we keep that in mind every time we do, surgery on patients. So, with that in mind, there's a whole song and dance to get people ready to get into the operating room. And some of it is psychological and social, and some of it is very medical, of course. So, but that process kind of roughly involves, meeting with the surgeon. Ideally, in my mind, meeting with a surgeon more than once. It's nice when you have the luxury of time to meet more than once, let people digest what they've talked about, come up with new questions, and meet again to go over those questions. Sometimes it's not feasible, but when it is, I think that's really nice. That process of having a conversation about surgery, what it entails, the risks, the benefits, the alternatives, that's what we call informed consent, and that's a really, really important process. I think Linda mentioned earlier this idea of imaging. Oftentimes when we're meeting patients, they've had, a fair amount of imaging done, but we may want to get additional imaging. So that's part of the process of getting ready. There is the pre-op evaluation, which is done by medical doctors or anesthesiologists who review the chart and may order additional tests like heart or lung tests or otherwise blood work to make sure the patient is as fit as possible and safe to undergo anesthesia for the surgery. We're also really lucky to have an incredible dedicated team of nurses that support us. So we have nurse educators that often either run classes and or meet with patients ahead of time to help them think about things like, planning your life around being away in the hospital for a few days or being out of work, for a few weeks and that kind of thing. So it's great to have that support. Like most major surgery, patients have to stop eating and essentially fast around midnight the day before surgery. We go over the medications that they should continue or should, stop. And then one of the big questions when people are getting ready for brain surgery has to do with hair shaving. That's a very, very common question. And what we tell people is, nowadays we tend to actually shave very little hair for the most part. It's really uncommon, unusual for people to need to do anything special for that. In other words, don't get a special haircut for brain surgery. We can take care of that often in a way that, minimizes how much hair is shaved. And then once you get into the hospital, then the rest of it, there's a really nice routine to take people, from that point all the way to getting out of the hospital after that.
Great, thank you so much. It's interesting to hear that, you guys aren't shaving people's hair as much as maybe before. I'm sure it's a comfort to some people or most people. Dr. B, let's keep moving through the process here. So what happens after a craniotomy or neurosurgery? If patients receive anesthesia, do they wake up in the operating room? Where do they go next? How soon can they go home?
That's
Can you
a
talk
great
a little bit
question.
about that?
And of course, no two patients are alike. So in general, patients do get extubated if they are intubated, meaning put under general anesthesia within the operating room. Usually they can't remember that portion of the day because they're still a little bit sluggish from emerging from anesthesia. They will go to either the ICU, the intensive care unit, or the postoperative recovery area. And that's a decision made based on the complexity of the case, the perceived postoperative risks. Very often, amazingly enough, for patients who undergo a routine craniotomy for tumor, the surgery itself takes just a couple hours and they can go to the regular recovery area. Well, they'll be watched for a few hours to ensure their blood pressures are stable, and then go to the regular neurosurgery step-down floor. More complex patients or cases that require a longer day, delicate handling of the fiber of the blood vessels or critical areas of the brain, those will more often go to the intensive care unit. I would say that across all of the brain tumors that Dr. Arnott and I operate on, the majority do not need to go to the intensive care unit in this day and age, which is a shift compared to just even a few years ago as well. The anticipated length of stay in the hospital depends on the function of the patient prior to surgery, as well as the risk of the surgery. The patient is perfect before surgery without any deficits, and it's a low to medium risk surgery, they very well could go home even the next day. That's often shocking for folks that they can be in the hospital for just a day, day and a half after brain tumor surgery, but I would say that's more than the norm, 1 to 2 days in the hospital. For folks who have issues, including weakness or confusion before surgery, whatever symptoms they have could be magnified after surgery. And so that may entail a longer stay, as well as a course of hospitalization at an inpatient rehab center with where they may spend, a week or 2 weeks or however long it takes to get them maximally back to their baseline function.
Great. Thank you so much for explaining that a little bit more. It sounds like it really is going to be a case by case basis, but how amazing that, most people are really there for a short visit. Dr. Arnott, moving forward again through this journey here, how soon do patients come back to see their neurosurgeon in the outpatient clinic? And then what are some red flags or some signs that maybe would warrant them to come back sooner than that?
Yeah, so we typically would want to see somebody back within a week or two from surgery. I usually, aim for 7 to 10 days, but 14 days is also reasonable. So something in that time frame. The point of that visit is for us to obviously examine the patient, make sure that the recovery is on track, including the incision, healing. We often use sutures. Sometimes we use dissolvable sutures, but often we use sutures that need to be removed, and that's a great time to remove those sutures. And within that 2-week mark, most but not all patients will have some pathology results that are back. Most patients will have some form of post-operative imaging for us to go over. So it's a really good opportunity to kind of sit down, make sure the patient's doing okay, go over pathology, go over imaging, and then if the pathology dictates that additional treatment needs to happen, like radiation or chemotherapy, then we start the conversation about what that looks like as the patient also starts to get ready to meet other providers in the team. In terms of red flags, what I would say is at any point in the recovery process, if there's any concern, it's always a good idea to reach out. I mean, after brain surgery, just have a low threshold to reach out with questions. But specific red flags tend to be things that are largely not subtle. So we talk about new or increasing neurological deficits, like if you have weakness is getting worse, numbness is getting worse, trouble talking, vision issues. Those are all, things that should prompt immediate consultation. Seizures, again, not very subtle, but a new onset seizure or an increase in frequency of existing seizure could be a concern and should be evaluated. With any kind of major surgery, you have to worry about the risk of infection. As you can imagine, we keep track very closely of our rates, which are thankfully exceedingly low. But, signs of an infection like fever or redness or swelling or any drainage from the surgical site, those should be evaluated. Changes in cognition, the patient's ability to kind of understand what's going on, answer questions. And then, pain and discomfort, again, major surgery has some discomfort associated with it inherently, but thankfully, brain surgery tends to be a lot better tolerated in terms of pain compared to other major surgery like abdominal surgery or back surgery. And the majority of our patients go home on over-the-counter, medications like Tylenol, maybe non-steroidal anti-inflammatories, sometimes something a little bit stronger. But yeah, severe out-of-control pain is thankfully very unusual. And if that were to ever happen, that should prompt evaluation. So thankfully, it's really rare to see any of those things. By the time people go home, it's really uncommon for them to have to, quickly come back to the hospital, which is always a concern, even though, like Linda said, our patients tend to go home within a day or two. But those are all things that should be taken seriously and evaluated right away.
Thank you for giving us some of those examples. I think you put it well too, that, people should have a low threshold for reaching out. It sounds like better safe than sorry, just to send a message or call the team to see if you need to come in for a quicker visit if something's going on. Dr. B, you were talking a bit earlier about how neurosurgery is critical for getting an initial diagnosis and then managing a brain tumor. Are there any circumstances, though, where more than one surgery can help?
Absolutely. There's a couple different instances in which additional surgery can play an important role in the span of a patient's tumor care. The first is that of tumor recurrence. For the similar reasons as for a newly diagnosed tumor, which is to establish a diagnosis, sometimes tumors may go from a lower grade or less aggressive behavior to a higher grade or more aggressive behavior. And so there could be a role in establishing a diagnosis again, even in the setting of a known tumor. Other times, tumors can be under control for a while and then grow back with a very different curve of change. And so again, they could have symptoms, and a surgery in some circumstances can help again with either their quality of life or their quantity of life. Lastly, surgery can play a role in clinical trials, especially in the recurrent setting. Many clinical trials require surgery to obtain tissue, both to help inform the response to treatment, but also to advance our knowledge and science of brain cancer care in the future. And then one separate set of surgeries, which isn't completely directly related to the tumor, but indirectly related, is that of surgery related to a tumor causing complications, such as something called hydrocephalus, which I know we will discuss more in just a minute. And so surgery for replacement of something called a shunt is a common procedure following brain cancer.
Thank you, Dr. B. Dr. Arnaut, let's talk a little bit more about shunts. What is a ventriculoperitoneal shunt, and what is the role of placing that procedure in the care of brain tumor patients specifically?
Yeah, so the formal answer to that question, a VP shunt, as we fondly refer to it, is an implantable medical device that diverts spinal fluid from the brain cavity down through the chest area and into the abdominal cavity where it gets reabsorbed. Really what I explain to patients is it's really fancy plumbing. At the end of the day, you have a problem called hydrocephalus, which fundamentally has to do with normal spinal fluid that we all have, just having a hard time exiting the brain like it normally should. And that means that either there's an obstruction somewhere and fluid is getting trapped, or it means that the actual mechanism by which spinal fluid gets absorbed has become disrupted. And that can happen because of the brain tumor, it can happen because of the operation related to the brain tumor, or it can happen because of the radiation. I mean, or oftentimes it's maybe some combination of all those things. But either way, fluid has to go somewhere. The skull is a fixed, space. It's not going to get any bigger. And the VP shunts, ventriculoperitoneal shunts, are a solution to that problem. So they help by eliminating the spinal fluid accumulation. Typically, when that happens, patients are very symptomatic. They can have really severe symptoms like headaches and nausea, vomiting, and VP shunts will alleviate or eradicate those symptoms. And then, placement of a shunt can often facilitate the patient's care otherwise. By alleviating that problem, you can allow them then to go through the rest of their treatment like human radiation and not have to worry about, fluid accumulating. So they're really effective at managing hydrocephalus, but like everything else, they have their own list of potential complications. You know, they can develop infections like other types of plumbing that we have in our house. They can become obstructed, the drainage can get impaired, they can malfunction, they can break. So like everything else, we take very seriously, and it's a very commonly done procedure, but we always have to weigh, you know, whether somebody really needs it and only place it when it's absolutely necessary to place.
Great, thank you, Dr. Arnaut. Dr. B, just a quick follow-up question about VP shunts. Can patients have an MRI after a VP shunt placement?
Absolutely. That's a great question. Patients can have both MRIs and go through the airport alarms after shunts and surgery on the head. Shunts come in two general varieties. There are many brands, but two general varieties. One that is a programmable valve and one that's a fixed pressure valve. As Dr. Arnaut said, shunt is just plumbing. And so the valve is a regulator in the middle of that plumbing, connecting the two from inside the brain to the belly. The number or the setting of the shunt, the higher the setting, the higher the dam of like a waterfall. And so less water can flow over that. The lower the setting, the lower the height of that dam, so more fluid can flow over that. There can be different reasons and circumstances, but in essence, a fixed pressure valve does not change with the MRI. And so if someone gets a fixed pressure valve, often it's something we call a medium pressure valve, they're done. A variable pressure valve, which could also be chosen for different reasons, means that the patient needs to have their shunt setting checked, often just with a magnet or with an X-ray following the MRI.
Great, thank you so much for that overview and for the image. It really helps to visualize, you know, what's happening there. And thank you both, Dr. B and Dr. Arnaut, so much for providing this wonderful overview of neurosurgical care of brain tumor patients. I wanted to ask you both a couple of questions to end on before we answer some questions from our audience. Wondering, what advice would you provide to our patients as they seek consultation with the neurosurgeon? And are there any particular questions that you think are important for patients to ask to gain reassurance from their neurosurgeon?
I can take a stab at it if that's okay, and then I'll punt it to you, Dr. B. So, okay, so I think for advice, I think there's a couple of things to keep in mind when you're coming to see a neurosurgeon. You know, one is it'd be great to bring medical records with you. We often try to get those ahead of time, including imaging, but you know, lab results and everything else. If you've seen other folks beforehand, all that is really great to kind of bring along if you can. Whenever you meet a doctor of any sort, I would say it's great to have a list of medications, you know, especially blood thinners. Surgeons always have to worry about blood thinners, but all medications are important to know what you're taking. For the types of conversations that we're having with people, which tend to be, you know, pretty heavy duty, it's really important, I think, to the degree that it's possible, to have a support person. And that might mean a family member, it might mean a spouse, you know, an adult child or a close friend. But having another pair of ears there to kind of listen and ask questions and take everything in is really, really helpful. And then the last bit of advice is that, again, because these are heavy duty conversations, things can sometimes, questions that you might have in your mind can sometimes evaporate when you're sitting there in the moment. So to the degree that you can write questions down, or write down things that you really want to go over, like particular symptoms, before you come to the visit, that's really helpful, because then we can make sure by the time it's all said and done that we've had a chance to go over all those things.
I fully agree with that. You know, our goal is really to help each patient make the right decision for them. And in addition to being as informed as possible, we want to empower patients to get as much information, whether it's online, through us, through a second opinion, through whatever it is, because they have to, these are, no matter how much safe and routine we perform surgeries, there's risk involved. And I think developing the trust with the team who will be with them, you know, through the long and short of it is really paramount. So as we strongly encourage patients and their families to educate themselves as much as they can, to ask lots of questions, to go home, sleep on it, and then ask more questions so that they can truly feel comfortable with any decision they make.
Great, thank you both again so much. We hope all our patients will be able to meet you, but given both of your busy clinical practices, we trust the advice that you provided will be useful as they meet with other providers. Before we move to questions from the audience, I wanted to take a few minutes to ask a little bit about your research. And actually, there is a question from an audience member that kind of touches on this, I think. What current projects are you working on? And what developments do you see changing neurosurgical practice in the future? And this is a question for both of you as well.
Dr. B, do you want to go first?
Yeah, well, research is something very near and dear to us, because part of our role we're never satisfied, with the current results. We think that surgery has advanced a lot, but until every patient maybe is curable, even without surgery, there's more that we can learn. And so for me, my lab focuses on the translational molecular biology of brain tumors and skull-based tumors. We focus on a number of pathologies. Meningiomas is one area that we've made great strides in the past decade to understand both the genetics of meningiomas, and we help define our kind of molecular classification for meningiomas that's used here at the Brigham and Dana-Farber, as well as the tumor microenvironment of aggressive meningiomas, in hopes that we can have better options. I say meningiomas because many of them are benign and surgically curable. So it's really that subset that's more aggressive that we take a keen interest in. In addition, because of our interest in genomics and kind of applications towards patients and diagnosis, we have ongoing efforts focused on the genetic signatures of gliomas and brain metastases to see how different types of signatures can better predict response to treatment and help guide kind of tailored or precise treatment pathways for different patients.
Yeah, I mean, I totally agree with Dr. B. I think that, a lot for us who do this, we are very driven by the desire to kind of make things better for our patients. So I could similarly spend an hour talking about my research, but I won't. But I'll tell you that the theme for my lab tends to be how we can take artificial intelligence and apply it to the care of a neurosurgical patient. So we're really interested in many different aspects of this, but as examples, this idea of a virtual biopsy, can we take MRIs and pick up subtle signals on the scan that help us understand the nature of what we're dealing with before we even get in there with surgery? We're really interested in trying to predict the future and in many forms, in answering questions that patients have. For example, is my tumor going to come back? Where is it going to come back? When is it going to come back? How long am I going to live for? These are all questions that are really important that we all kind of, struggle with because we don't have good answers for. But we hope with AI and some of the techniques that are really rapidly evolving that we'll be able to get some good answers to those questions.
Thank you both for sharing that. Really fascinating work, and grateful to be able to talk to you both today. Let's answer a few questions from our viewers. So we have a question here from the audience. Can surgery happen on a larger tumor? And this specifically is a metastasized tumor. So a tumor from a cancer in a different part of the body that is spread to the brain after full brain radiation has been done. So can surgery happen on a large metastases after radiation has been done? And either of you are welcome to answer.
I would say yes. In fact, that's one of the reasons we do surgery after prior radiation. Radiation is probably the more common treatment for brain metastases. But after having whole brain radiation, that means that the tumor was resistant to the radiation and grew through that. So often, especially if a tumor is larger, if it was small, we might consider additional focus radiation. But if it's large, there's really nothing faster than surgery to kind of reset the clock and reduce the big clump of tumor down to the microscopic disease, for which radiation can then be more effective to that little, sprinkles of sand in the microscopic disease. So especially if it is a large recurrence after whole brain radiation for brain metastasis, surgery can play a pivotal role there.
Great, thank you. Dr. Arnauj, do you want to add anything?
Yeah, no, I totally agree. I mean, I think that the idea of surgery after radiation, that happens on quite a regular basis. So there's no reason why you can't have surgery after radiation. And then the size of the tumor in terms of being at large, I agree. I mean, that's one of the most common reasons why we would want to do surgery, because it's large and potentially symptomatic or problematic otherwise.
Great, thank you. Another question. How do oncologists determine a tumor has changed to a different type of tumor or a different grade?
So, I mean, I'll give you my hope for the future and kind of the current state. I mean, that's one of the questions that we're trying to answer in our research by trying to pick up subtle changes on the MRI. Now, there are changes that are not so subtle. You know, for example, you have patients with low-grade gliomas, and all of a sudden the nature of that tumor changes in terms of how much contrast it picks up on the scan, or the pace of growth. If all of a sudden things are picking up, those are hints that the tumor has likely changed grade. Ultimately, the only way to answer that question definitively is with tissue. The only way to tell if a tumor has gone from a grade 2 to a grade 4, for example, continues to be getting a piece of it out. So that is often a reason why we would consider surgery if there is concern by the oncologist or the radiologist or somebody else that the tumor is changing grades. We would want to intervene surgically, A, to get tissue diagnosis, and B, to maybe try to reset the stage a little bit to get the bulk of it out so that if additional treatment is necessary, we're starting in a good place to receive the benefit from them.
Great, thank you. Dr. B, follow-up question kind of. When is a biopsy recommended versus a full-blown, resection, craniotomy? This is another question from an audience member.
Yeah, and I would say for this, it's a nuanced question, and it really depends on the perceived pathology of the tumor. For example, some pathologies like a suspected lymphoma, a biopsy is much more commonly pursued, whereas others like gliomas, even metastases, if we can safely remove it, we would try to safely remove it because the extent of resection has been tied in with survival benefit. In general, I would say, and also the location and risk of the tumor. A tumor that's a clumped ball, what we call a nodular tumor, is safer to remove from most areas of the brain, whereas a tumor that's like a spread out like a pile of sand or powdered sugar in the brain, what we call a diffusely infiltrative tumor, would be less amenable to removing the whole thing because there'd be normal brain embedded in that. And a biopsy would be more appropriate there. So there are different factors, including the tumor basis, the location basis, the patient status base, whether they're sick or well enough to undergo a larger surgery, the pathology basis, and also, whether or not just taking out more tumor can help with the symptoms and the quality of life of the patient.
Thank you. It sounds like it's a complex answer in terms of all the factors that have to be considered. But thank you so much for that answer. I know we touched a little bit on this already, but we have a question about specific clinical trials. I'm wondering if either of you have any clinical trials that you're either participating in or you know of at the Brigham and Women's Neurosurgery Department, and whether or not there have been any developments with those clinical trials.
I mean, the short answer is yes, absolutely. There's a ton of clinical trials, and there are, of course, there are plenty of non-surgical clinical trials with gliomas, for example, other types of tumors. But through the collaboration with Dana-Farber, there's a fair amount of surgical clinical trials. In other words, there are trials where patients are getting micro devices implanted that allow for the continuous infusion of medications or immune active agents like vaccines. There are also what we call neoadjuvant trials, there's been quite a few of those recently where patients, especially with gliomas, will have a drug treatment before surgery, and then, usually within 2 weeks of that infusion, will come in for tumor resection. And we're looking at lots of different things. We're looking at how much of the drug makes its way into the tumor tissue, and of course, the effect that it has on the tumor tissue. So just like we are in our research world, we're very involved in the clinical trial world from the same desire to kind of improve. Now, that being said, the frustrating answer is, despite all that effort, and that will continue to be an ongoing process, when it comes to high-grade gliomas or glioblastomas, there has not been much that has dramatically changed the needle on that. Really one of the best things we can do for patients that are appropriate for it is an aggressive upfront resection that continues to be one of the most helpful things we can do for them. But we've yet to find the type of success that we have found with other types of tumors, where the landscape has really dramatically changed over the last few years. But we are very optimistic that it's only a matter of time. I mean, it has to be that one of those trials, if not more, will pan out. And it's worth remembering that some of these really exciting advancements that have happened for certain types of leukemias and lung cancer and melanoma, some of which are radical innovations that happened here in Boston, those came out of clinical trials. So we're hopeful that happens. We'll continue to be engaged in clinical trials until that happens, and we're very involved in them.
Thank you. Dr. B, would you like to add anything?
I fully agree with Dr. Arnott, although it can seem frustrating for the number of positive trials, but I do think it's an exciting time. If we think back, the Cancer Genome Atlas and the first profiling of gliomas or glioblastomas in general was only 10 to 15 years ago. Just last year, several landmark studies came out, including the efficacy and role of IDH inhibitors in gliomas, which is a huge class of these tumors. So I think there are a number of very exciting breakthroughs at the cusp, and that hopefully the curve of those breakthroughs is continuing to increase.
Great, thank you. Let's talk a little bit about technique, surgical technique. What are some common craniotomy techniques? This is from the audience. Are there any new or innovative techniques you feel are particularly promising?
Yeah, so I think, as far as technique goes, I give this talk where I talk about kind of how things have improved across the spectrum in the past 10 or 15 years of the whole process. So anesthesia has improved, imaging has improved, navigation has improved, and surgical technique, instrumentation, our ability to stop bleeding. I mean, all those things have improved, and they all kind of come together to basically, the way you end up with patients having brain surgery and more likely than not going home the next day is because we're able to minimize our footprint. We can go into somebody's brain and we can resect something, and they can feel and look well enough to just walk out of the hospital essentially a day later, because we're able to minimize disruption to the surrounding everything, to the muscle, to the scalp, to the skull, but most importantly to the brain. It's really how disruption happens. So the way we can not compromise, but rather maximize the extent of resection while minimizing our footprint to everything else around it. I think that certainly has evolved over the past 10 or 15 years.
I fully agree. A lot of the evolution in technique is to make surgery safer and more effective in terms of getting more bang for the buck. I do think that although different types of surgical approaches and tools are available, but the newest doesn't mean the better. Newer doesn't mean better by any means. And there can be sometimes a misperception, that just because something is a newer tool, that it might be better or less invasive. I think that really has to be judged case by case and with an experienced neurosurgeon based on the individual pathology and tumor and location at hand.
Great, thank you so much. Last question for you two, and then we will wrap it up. This is another question from the audience. And it's a good one. Once a patient is finished with surgery, how does a neurosurgeon or the neurosurgery team work with the neuro-oncology team or the neuro-oncologist and or the radiation oncologist with ongoing care?
So there's a couple of answers to that. One is that this relationship that you as the patient and the family have with the surgeon is not an episode. It is when I tell people it's a lifelong relationship. So once we've done brain surgery on you, we're married forever. And so you'll always have your surgeon kind of at your disposal for questions or concerns, even if you never have a second brain surgery. That being said, like Dr. B said, the team that takes care of brain tumor patients often has three main actors: the surgeon, the neuro-oncologist, and the radiation oncologist. And at different stages of the journey, one or maybe two of those people kind of rise to be kind of at the forefront, but the rest of us are always here, sometimes behind the scenes. We meet on a very regular basis. Matter of fact, we all met this morning, as we do every Monday, to talk about newly diagnosed patients in a very multidisciplinary way. Neuro-oncologists, radiation oncologists, radiologists, pathologists, surgeons are all on that call. So we discuss all patients. And then on an ad hoc basis, on an ongoing basis, it's a very small, very tight-knit community of providers that take care of brain tumor patients. So we are in communication multiple times a day on a very regular basis talking about patients. So you may be seeing one person in clinic, one of the three of us, but all three people are constantly talking about the care behind the scenes.
I fully agree. Yeah, we're so fluid as a team together, and I think finding for anybody with a brain cancer, some cancers don't require all domains, especially brain, more benign brain tumors. One facet of this triad of care emerges more so than others, but being at a center where one can access, all these different domains with great agility is very important to brain tumor care.
Thank you both so much. I think from my experience, just observing patients here, it really does seem like one big team, neuro-oncology and neurosurgery and radiation oncology too, sometimes really are all working together. Like Dr. Arnaut said, you may be meeting with someone, but usually there is crosstalk often between doctors. So that's one of the really special things about Dana-Farber. Thank you guys so much, Dr. Reed, Dr. Arnaut, for this comprehensive discussion on neurosurgical care of brain tumor patients. Any take-home points? We're up on time, but if you have any couple of words you want to leave us with, now is the time.
I think it's a phenomenal series that you and the team have put together. I mean, what an incredible resource. And we're so grateful to have so many patients joining us and to be able to, hear their questions and be able to help clarify a few things.
Yeah, I agree. Thank you so much for setting this up. I hope people find it useful. It's always nice to engage with, patients and their families. So thank you for creating the forum for that to happen.
Absolutely. Thank you both again so much for being here. And please do join us next month, May 17th at 3 p.m. We're going to be discussing radiation therapy with Dr. Sham Tangaturi and Rif Rahman. So thanks everyone so much for joining, and hope to see you then.
I briefly just want to echo Rachel's comments. We really appreciate both of you taking your time to come join us today. And as mentioned, this was recorded and will be posted on our Blum YouTube playlist and our Digital Resource Center.